you. So, hello everyone. Assalamu alaikum. Good morning, good afternoon, wherever you are joining us from different parts of the world. We welcome you to this session today. This, as you may know, for those of you who are joining us again, this is the Health and You Community Wellness Series. And the overall goal of the series is really to create community awareness about health and disease. The ultimate objective of the series is to enhance self-care, reduce suffering, improve the quality of life, and increase healthy longevity. So I'm Dr. Suhaila Chima, and we would like to warmly welcome you to this session today. I'm the Assistant Dean for the Institute for Population Health here at Weill Cornell Medicine in Qatar, and an Associate Professor of Clinical Population Health Sciences. So just to go through some housekeeping rules, your cameras and microphones have been turned off. Please use the question and answer feature to type any questions or comments. You can also just put your question or comment in the chat. We will be able to see them. So in case you don't know where the Q&A tab is, please go ahead and just put your question, comment in the chat, and we should be able to review it. Just as a reminder, we will be moderating the questions at the end of the sessions. I will moderate the Q&A session. And again, this is not a continuing medical education or a continuous professional development activity, and no certificates of attendance will be issued. So the topic today is really, really interesting. As you can see, the title of the session today is The Eye, Common Issues and Red Flags. So it gives me great honor to introduce our speaker today. His name is Dr. Mohammad Samara, and he joins us from Hamad Medical Corporation. He is a medical doctor. He graduated from Hashemite University, Jordan, and he's been working at Hamad Medical Corporation in ophthalmology since 2019. So Dr. Samara, thank you so much for joining us today and doing this for us. We are really, really grateful to you. And thank you so much for taking the time out, to talk to our community and helping them, again, to become more aware about what eye health is. Over to you, and a very warm welcome to you again.
Thank you, Dr. Suhaila. Thank you for having me. I'm very happy to be here. Hello, everyone joining. I am Dr. Samara. I'll be presenting a short presentation about the most common issues people come to our clinics with in ophthalmology, along with the most important emergencies and the most important red flags that need to be addressed urgently. I'm gonna share the screen now. Okay. Are the slides, can everyone see the slides?
Yes. Yes, thank you.
Okay. Okay, so I divided the lecture to the most, I will start by talking about the most common causes of red eye. Even if red eye is not painful, it's a very worrisome sign for patients, and it might cause some anxiety for the patients. So we'll address which causes of red eye need urgent care and need management, and which causes of red eye might be self-resolving. And of course, we'll be talking about decreased vision, which is the most important and the most scary thing for patients whenever, however the decreased vision is, whether it's gradual or sudden. And also I will talk about ocular emergencies, including ocular traumas. And I dedicated a part at the end to talk about diabetes and the eye, because a really big percentage of the patients we see in our clinics, especially the retina clinics, are there solely because of uncontrolled diabetes. And again, with control of diabetes, most of these issues that might cause permanent vision loss are very avoidable. And also glaucoma is very prevalent. I will just define what glaucoma is, and because it's a silent disease, I will just talk a little bit when to get screened, and who to get screened for glaucoma. Okay, so I'll start with the conjunctivitis, which is very, very common. Conjunctivitis, as a definition, it's the inflammation of the conjunctiva, which is the transparent layer covering the sclera, the white part of the eye. So when it's injected, it will give you the red eye. That's the sign for patients. So it has many causes, but the most common causes we usually see are bacterial, viral, or allergic. So usually if it's bacterial, usually it starts up in one eye, and 1 to 2 days after it will go to the other eye. The discharge is usually very purulent, very sticky. It's yellow and green, and usually people will complain then that when they wake up, their eyes are stuck together, and they need to use their hands actually to open their eye. The good thing about bacterial is that it's usually the duration is very short. It's very short limited. It usually just self-resolves without any other issues. In some cases, we might need to prescribe some antibiotic eye drops, but not necessarily. Viral conjunctivitis, it's basically the same presentation of bacterial, but you wouldn't have this thick yellow discharge. Usually it's red, itchy. Usually both eyes are affected at the same time. The thing about viral, usually it takes 5 to 7 days to resolve completely, but some subsets of viruses might have an extended period. The symptoms might stay for 2 to 3 weeks, and they might cause some scarring to the cornea of the eye. So usually what we tell patients with viral conjunctivitis, if your symptoms are prolonged and the issue is still there after 1 week or 10 days, it's better to seek medical help. The other cause of conjunctivitis that we very commonly see is allergic conjunctivitis. It really looks like viral. We actually make we distinguish between them on the slit lamp. When we examine the patients, we look under the eyelid and see how the pattern of inflammation in the eyelid is. Usually allergic conjunctivitis has a trigger. So if anyone is diagnosed with allergic conjunctivitis, we usually ask them questions on what might cause this. So many patients will report dust exposure. So many patients will actually report changing the kind of perfume they use, even the laundry detergent on the pillow casings might actually trigger an allergic inflammation of the eye. So once we diagnose allergic conjunctivitis, we might give a topical steroid and for the short-term relief of the symptoms, and we would give with it an eye drop that should be taken for a month or two. This one will provide long-term stabilization of the inflammation in the eye. So these are the main points about conjunctivitis. Going to a more serious issue, keratitis. Keratitis is when the infection where the infection reaches the cornea. So this is very common. This is a very common cause for admission of patients in our inpatient ward. The two most common causes for developing keratitis are trauma to the eye, any history of trauma to the eye, and the most avoidable one is contact lens wear. So this is a message to anyone who wears contact lenses. It's very important to maintain contact lens hygiene, meaning if you use the daily type, discard of it do not use it over more than 1 day. If you use the monthly type, you have to remove it on daily basis also, and you can use it over the period of a month. That's okay, but do not sleep with the contact lenses, do not shower, do not swim while wearing the contact lenses, because infections that happen with the contact lenses are usually severe and might cause permanent damage in the eye, and might cause a very serious infection, and it might actually perforate the cornea and spread into the inside of the eye. So again, contact lens hygiene is a very important aspect of eye care. If at any point while wearing the contact lens somebody starts developing a red eye or a painful eye, please remove the contact lens, keep it with you, seek urgent care. If there is an infection, we might need the contact lens itself to take a sample of it to know which agent caused the infection, which bacteria usually. So some cases of keratitis are mild. We would give eye drops and monitor the patient closely, but more severe forms of keratitis actually require us to admit the patients on something we call fortified eye drops, which are very powerful eye drops of antibiotics that we make in our pharmacy. It's very important to monitor. Cases we admit are very important for us to monitor on daily basis, so that in case of any need for any further intervention, we do it on the same setting. Another cause of red eye and is anterior uveitis. So anterior uveitis is a somewhat complex entity, but it's an inflammation of the eye. It's not necessarily an infection, though it might be caused by infection. So it's usually inflammation of the eye that causes red eye, dull aching pain of the eye, and it can cause decreased vision. So usually it might whenever someone develops anterior uveitis, it's important to seek urgent help from the ophthalmology that is available in the emergency department, because we need to start on heavy steroid eye drops that can be given every 1 hour. And we have to give some eye drops to keep the pupil of the eye dilated, so that the pupil, because with inflammation, the pupil might get stuck and cause multiple other issues in the eye. A subset of anterior uveitis, a percentage of anterior uveitis, is associated with rheumatologic diseases. So usually we check these, anyone who comes with anterior uveitis, we check them for rheumatoid arthritis, seronegative arthritis. We check them for a bunch of the immunologic diseases, because for some of these diseases, any attack of anterior uveitis is a flare-up to the disease, and we need to consult rheumatology, so that rheumatology might start them on immunologic treatment or systemic steroids. Okay, so these are the most common and worrisome causes of red eye. And now I'm going to talk about decreased vision. So if at any point you find yourself not seeing in the eye as you usually see, you have to ask yourself these questions. Is it painful or painless? Is the decreased vision you're having associated with pain, or is it painless? Did you develop the decreased vision suddenly or gradually? Is it one eye or both eyes? And if it's both eyes, is it the same degree in both eyes? Is it transient, meaning did the vision decrease a little bit and came back to normal, or did it happen and it still decreased? Stable or progressive, meaning when the vision loss happened, is it the same throughout, or are you losing more and more vision on daily basis? And importantly, any past ophthalmic history. Have you had any surgeries in the eye? Do you have any history of nearsightedness, especially people who have nearsightedness of more than 4 or 5? Uh, this is very important. These are very important questions because so many of these questions are actually red flags, because a sudden loss of vision, of course, is more urgent, is more worrisome for us than a gradual decrease of vision. If it's affecting one eye, it will indicate for us that the cause is the eye itself. If loss of vision is in both eyes, suddenly this might be something more severe, something more urgent, something neurological. Is it transient also? And if it's transient, how long did you lose the vision for? So any past ophthalmic history, because any eye that has severe, high nearsightedness, or any history of previous surgeries in the eye might actually be a red flag for retinal detachment. And that is one ophthalmic emergency that we're going to talk about later on. So one of the most common presentations for patients, one of the most common diagnoses we reach with patients is cataract. So cataract is, by definition, it's when the lens that's inside the eye. So every eye has something called the crystalline lens. It is a structure that is behind the iris. It's important. It's transparent throughout your life. With aging, it might get opaque a little bit, and this opacity is called cataract. So cataract is still worldwide one of the most common causes of vision loss, and it's still the most common cause of reversible vision loss. So cataracts happen with aging. It is a normal process, but again, there are some conditions that if any patient has, will cause accelerated cataract. Meaning, some patients will develop this cataract on an earlier stage. The most important is, of course, diabetes. Diabetic patients and uncontrolled diabetic patients and patients with high blood sugar levels throughout the day and with high HbA1c levels tend to develop cataracts faster. So once we diagnose the patient with a cataract, we just need to make sure that there's nothing else causing the decreased vision in the eye. So we need to take a look at the retina. If the retina is okay and the only cause of vision loss in the patient is cataract, the solution is a surgery. This surgery is removal of the lens that's inside the eye and insertion of a foldable intraocular lens that stays in the eye forever. It does not cause any issues. It's one of the most common performed surgeries all over the world, and it's performed in HMC on daily basis. So it's important in the cases of so the old teaching about in cataract was they used to tell the patients that it's better if you wait for the cataract to become mature, meaning like the picture you can see, the cataract is white. It's a white opacity. Now, because the surgery that was done at that point need the cataract to be this solid. Now with the newer devices and the that are readily available, cataract is removed once it becomes bothering the patient, which is subjective and it might differ from a patient to another. But at any stage, the cataract surgery can be done. Once the patient is not comfortable with the vision, the surgery is done. So after the surgery, the lens that is put inside the eye is usually a lens that will give vision to the distance. So which means that if the patient needs glasses for driving or watching TV any any activity the patient does on the distance, they will not need glasses for it, but they will need reading glasses after. So these are the main points about cataracts. It's very common. The surgery has a success rate between 90 to 95%. And patients usually are very happy after the surgery, and no issues will arise. The other cause, the another is vitreous hemorrhage. So vitreous hemorrhage is bleeding inside the cavity that's inside the eye. So this issue is behind the lens in front of the retina. So what does the patient complain of? Usually it's a sudden loss of vision. Usually the patients will complain of thread-like black spots or spider webs, as the patients would describe, that they are seeing in front of the eye. Who develops vitreous hemorrhage? Again, the most common cause of vitreous hemorrhage that we see on daily basis in the emergency is diabetic eye disease. So usually the patient is a diabetic patient with poorly controlled blood sugar, and usually the patient does not seek ophthalmology advice since the diagnosis of diabetes, meaning the patient will develop the predisposing factors to get the vitreous hemorrhage, and suddenly one of the blood vessels will bleed, and it will cause this decreased vision. So once the diagnosis of vitreous hemorrhage is done, is reached, of course, if it's diabetic vitreous hemorrhage, the patient will need laser. This laser is in hopes of preventing the hemorrhage from happening again, but again, if laser is done and laser worked beautifully, and the patient did not control the blood sugar, bleeding might happen again. This hemorrhage might happen again. So it's very important. The first, second, and third thing we tell the patients who get vitreous hemorrhage, diabetic vitreous hemorrhage, is please control your blood sugar. So after the patient develops the loss of vision, usually within 1 week, the blood will settle down and the vision will become more clear. Once the vision is clear for the patient, that is the time where we can interfere and do the laser, because like the patient, to see into the retina, it's hard for us to see with the blood filling the eye. So it's important. What we tell the patients is stay in a semi-sitting position, avoid cough or any exercise, any lifting heavy weight, so that the hemorrhage does not increase. Other causes of vitreous hemorrhage can be traumatic, and it can be something called posterior vitreous detachment, which is when the gel that's inside the eye separates from the retina, which happens in 90% of the people and does not cause any issue. But sometimes it might just shear a blood vessel, and this blood vessel will bleed and cause this. So in a patient like this, we would give the same instructions: keep your head up. And once the hemorrhage has settled, we have to scan the retina to look for any breaks or anything that we can laser, so that this break does not progress into a detachment. So again, cataract and vitreous hemorrhage are a big chunk of the patients who come with decreased vision. Vitreous hemorrhage is usually sudden. Cataract is usually gradual and progressive. So this part now, I'm going to talk about the ocular emergencies. So the ocular emergencies that I'm going to talk about are two of them are traumatic, which is any ocular trauma penetrating or blunt, or chemical splashes or chemical injuries that happen to the eye, and what to do immediately. And the two big emergencies in ophthalmology, which are retinal detachment and angle closure. So, retinal detachment. So usually the retina uh, is the retina has two main layers. A layer we call neurosensory retina, which is responsible for absorbing the light and taking in the image from the outside. And there is a base that this neurosensory retina is attached to. So retinal detachment is when the neurosensory retina detaches from the RPE, which is the layer that is below it. This is an ophthalmic emergency because because once the retina is detached, it means this retina is not getting the nutrients, and it's at risk of death and scarring and permanent vision loss. So, what are the symptoms of retinal detachment, and who is at risk for developing retinal detachment? Patients with extreme nearsightedness. If you wear a glass prescription, which is -5, -6, around these numbers, this is there is a risk for there is a higher risk to develop retinal detachment than normal people. Any previous eye surgery, mostly cataract surgery. So cataract surgery, as simple as it is, it's still a surgery, and it carries on a risk. It's not a big risk, but it carries on a risk of developing retinal detachment in the future. Trauma, because trauma might cause breaks in the retina. Trauma might cause vitreous detachment, and all this would might cause breaks into the retina and detachment of the retina. If there's detachment in the other eye, there is a 15 to 25% risk of detachment in the other eye. So it's important if retinal detachment happens, God forbid, to check the other eye. And family history of retinal detachment. We there are some syndromes, and even patients who don't have syndromes, family history of retinal detachment means you are at a higher risk than the general population to get a retinal detachment. So this picture shows what a patient with retinal detachment usually sees. The black part in the corner is the detached retina. So usually the patient is not seeing well up and out, supposing this is the right eye, which means that the opposing retina is what is detached, because the retina gives the picture inversed. So with these presentations, with this presentation, the patient needs to seek emergency ophthalmic assessment. Luckily, in HMC, you have a 24/7 ophthalmology on call. Once we get the diagnosis of retinal detachment, we will explain to the patient the type of detachment they have. I'll come to that later, and how and what to do. So most of cases of retinal detachment will need surgery for repair. The surgery is done daily in HMC, and the surgery can be done on urgent basis and less urgent basis. Let's call it that. So, if the detachment of the retina already reached the center of the vision, meaning we have an area called the macula in the eye, which is the center of the vision. If this area is involved in if this area is also detached, surgery can be done it can be done from 1 to 10 days after the presentation. But the real emergency retinal detachment is when the macula is on, as we call it, which means that the detachment is still a little bit far away. It did not reach the center of vision. So in a patient like this, we admit them for urgent surgery within 24 hours to make sure that the center of vision is not involved. So what are the signs and symptoms of retinal detachment? So sudden appearance of floaters. So usually the patient will report multiple black spots in the field of vision, which are tiny specks. Flashes of light, meaning the patient will, while moving the eye or while looking, will suddenly feel something flashed inside the eye. Flashes of light means that something is pushing on the retina and it might be breaking. Blurred vision, once the vision is very blurry, this is a bad sign. It means that probably the center of vision is involved. And in more meticulous patients, in patients who are more observant, they might come saying they cannot see, they don't have peripheral vision. So the key word in retinal detachment is sudden. Once you develop any of these symptoms, you need to seek emergency care. Because again, if the center of vision is not involved and the surgery is a success, you save the eye. You're not gonna have any other complications. You're not gonna have any issues with your central vision, which is the most important part. But if the center of vision is already involved, surgery will be done. The surgical success will be 90%, but we cannot assure how much vision will be regained. So it's very important. It's really important that whenever any of these signs happen, to go to the emergency. Floaters is a very common complaint. Most of people who have floaters do not have a retinal detachment, but it's worth having your eye checked when you have floaters in the eye. So that's it for retinal detachment. Usually once we reach diagnosis, surgery has to be done. Surgery will aim to put the retina back in its place, and the visual and regaining the vision after depends on the situation of the retina itself. The other emergency is angle closure. So angle closure is when the iris, the colored part of the eye, in its peripheries and its far away parts, closes on the retina, on the cornea. When this happens, aqueous, which is the fluid inside the eye, will not be drained outside the eye. The pressure in the eye will build up. It will reach 2.5 to 3 times the normal limit. The patient will have severe eye pain, severe redness, headache. Patients actually will come with vomiting when they have angle closure. So angle closure is an absolute emergency. Usually the patient will come with red eye, pain, and decreased vision. Once we diagnose angle closure, we will check the pressure of the eye. Usually the pressure will be 40 to 50, and the normal pressure should be 10 to 20. So it might be 4 to 5 times the normal limit even. So once we reach this, we have to give intravenous medications. We have to give IV medications to decrease the pressure. Once the pressure is back to normal, patients with primary angle closure will need, we would do something called a laser iridotomy. We will use laser, make an opening in the iris. This opening will make sure that the fluid is rotating in the eye and moving normally in the eye, and the attack won't happen again. Usually, if we diagnose angle closure in one eye, we do the laser in both eyes to prevent the attack happening in the other eye. People who are at risk for angle closure are it's like the opposite of retinal detachment, when patients are farsighted, patients who wear glasses that are plus. It's more common in female. females, and East Asian ethnicity. And of course, family history of angle closure is a risk factor of angle closure, and older patients are at a higher risk to develop angle closure. Because also older patients might actually have cataracts, and the cataracts might cause some physical element of pushing the iris against the cornea. So once we diagnose angle closure, we have to decrease the pressure in the eye. We will give IV medications. Once the pressure is low and we are able to see the iris clearly, we will do laser to both eyes. We will make openings in the iris for both eyes to make sure no attacks happen again. So the last part is going to be ocular trauma. So ocular trauma, I'm going to talk about two subjects, which is direct trauma to the eye, whether blunt, whether it's penetrating. And the other part is going to be chemical exposure, because it's very common, and it's really important to say explain the emergency management of chemical exposure of the eye. So ocular trauma. Ocular trauma can be blunt or penetrating. Penetrating means a sharp object hit the eye and caused an opening in the eye that is extending full thickness, which means that the integrity of the globe is at risk now, and the globe is open to the outside world, which will make it at a higher risk for infection. So if somebody gets any penetrating trauma, it's important to put a shield in the eye, not a patch. Avoid pressing the eye. Just put a shield around the eye, make sure nothing else hits the eye, and go to the emergency directly. Because penetrating trauma will need emergency surgery and suturing. So this is a picture of a penetrating trauma, which is involving the cornea of the eye and also part of the sclera. So in a case like this, patient has to be admitted and emergency surgery should be done. The other form of trauma is blunt trauma, which is trauma with a non-sharp object, but it will cause injury to the eye. So usually the injuries with blunt trauma might be apparent, but sometimes it might cause hidden injuries. So a blunt trauma will affect the eye as a whole. So you might have injuries in the frontal parts of the eye, you might have hidden injuries in the retina, or sometimes the injury might be severe enough to actually cause injury to the optic disc of the eye. So it's important to seek in cases of penetrating trauma. And all penetrating traumas, you should go to the emergency. Blunt traumas that are severe, that are causing significant eye pain, that are causing significant redness, that are causing significant vision loss, these are the ones that you need to seek emergency medical help for. So this is a patient who had a blunt trauma to the eye, which caused bleeding in the anterior chamber of the eye. So this is a bleeding behind the cornea in front of the iris. Usually in a case like this, we might admit the patient to monitor the eye, and once the eye is less inflamed, we would do a full checkup for the eye to make sure there are no hidden injuries in the behind the eye. Okay. Chemical injury to the eye. So just what to do when you're exposed to any chemical. You have to wash with water immediately, which means you open your eye under a water source for 15 to 20 minutes so that you balance the pH, you balance the acidity or the alkali of the substance that went into the eye. And please do not wash the eye with anything other than water. We have patients who come into our emergency who had burn with some acid, who wash their eyes with milk. This is worse. This will cause infections. This will cause way worse issues than it would have if you'd washed your eyes with water. So chemical injury, you seek immediate medical help. So wash with water, seek help, keep your eye under tap water until help arrives. Probably once you get to the emergency, you'll get another eye wash. Usually, most of chemical injuries we see are gonna resolve, but in some cases, the chemical injury might be severe because the patient might have the injury with a very powerful substance, very strong acid, or a very strong caustic soda, for example, and we might get a picture like this, which might be a cause for corneal blindness. Another part I want to talk about is diabetes and the eye, because a big percentage of the patients we see in our clinics are coming because of diabetes, especially the retina clinics. Retina clinics are filled with patients who had diabetic issue, who have diabetes, did not keep it under control, and developed irreversible damage to the retina. So what diabetes will cause in the eye can be retinopathy, which is direct damage to the retina, macular edema, which is fluid which is fluid in the retina. It can accelerate cataracts, and in some cases, it might cause glaucoma. So when to get screened for diabetes? If it's type 1 diabetes, 3 to 5 years after the diagnosis. If you're diagnosed with type 2 diabetes, you have to be immediately referred to an ophthalmologist and have the checkup. If there's nothing, if everything is fine and there's no retinopathy or macular edema in the examination, this examination is done on a yearly basis. Otherwise, if there's macular edema, you might need the injections that are given inside the eye, and laser in cases of vitreous hemorrhage or any abnormal blood vessels happening that are forming inside the eye. Again, none of the interventions that are going to be done for diabetic eye disease will work if the blood sugar levels are not controlled. So the HbA1c that we prefer is usually around between 7 and 8. Once it's above 8, then problems to the eye will start happening. Last subject I'm going to talk about, because it's also very common in our clinics, is glaucoma. So glaucoma is a group of diseases that will damage the optic nerve. Usually they are associated with high pressure of the eye. So it's either open angle or closed angle. The thing about glaucoma is that it might not have any symptoms, so patients might present on a late stage. Usually, once we diagnose glaucoma, we give eye drops to decrease the pressure. If there's progression, laser can be used. If the patient's vision is getting worse and the glaucoma and the damage to the nerve is getting worse, surgery can be done, and it's reserved for refractory and advanced cases. These are the changes in the visual field. So as you can notice, the changes in the visual field in glaucoma are usually start from the peripheral parts and crawl into the center. So in picture G, you can see this is a tunnel vision, meaning that all the periphery are gone and the patient can basically only see through a small part of the eye. So who to screen? One last thing, who to screen for glaucoma? If during your normal ophthalmic exam, the ophthalmologist notices that the optic disc looks somewhat suspicious, they will order further testing. If you have family history of glaucoma, you should also do some screening for glaucoma. So the screening is, the doctor is going to take a look at the disc, the optic disc of the eye during the examination, and we're going to do some scans for the visual field and the optic nerve. Thank you. That's it. I'll take the questions now, if it's possible.
So thank you very much, Dr. Samara, for that wonderful presentation. I would like to commend you. I think you covered a lot.
Yeah, it took a little bit too long. I'm sorry.
No, actually you didn't. And I'm really surprised that in this 45 minutes, you've actually done a wonderful job. you've been able to actually, review a lot of different diseases and, the context for different eye problems. So thank you so much for that. So I think it's been a very informative session, and we're really, really grateful to you for doing that. We have received several questions, so I'm
Yeah.
going to just go ahead and, just ask you that. The first one that I would like to ask you is that one of our participants is asking, in the case of allergic conjunctivitis, when you're aware that allergies such as pets or dust can cause it, is there anything that you can do preventatively?
Okay, so in allergic conjunctivitis, it's like any other allergy. The first thing is to do is to avoid the trigger. But if you love your pet way too much, we can,
Yes.
there is once it flares up, we can give a short course of steroids, which lasts for 2 weeks. But
Okay.
along with the steroid, we will give another eye drop, which is a mast cell stabilizer. This
Okay.
eye drop, it will take longer to work, but it will keep the inflammation in the eye at bay. But again, if the exposure to the increases, the allergic conjunctivitis might happen again. And in some cases of allergic conjunctivitis are actually very resistant to treatment. It's one of the hardest conditions to treat.
Mhm.
So in mild to moderate cases, it's manageable by steroids and mast cell stabilizers. In some cases, we might need to do extra measures, might need
Great.
some systematic treatment.
Thank you. Thank you so much for that explanation, because of course, people who love their pets,
Yeah.
they're okay having eye problems or other problems with them, but they still want to keep their pets. So anyway, thank you so much for giving that answer. We'll move on. We have a lot of questions on retinal detachment.
Yes.
So one question is, can people with a family history of retinal detachment avoid having the problem? Is there any way of reducing the risk?
The thing is with retinal detachment, there is nothing to be done to avoid it. But
Okay.
the the thing you can the only thing you can do is get regular screening. You're gonna have an eye exam that is done maybe once a year, or whenever. The thing is, whenever you get floaters in the eye, whenever the
Right.
floaters in the eye are more, it's important to go, because the
Right.
predisposing factor for retinal detachment is a retinal break.
Okay.
So if we diagnose the retinal break before it becomes a detachment, we will just laser around the break and will
Mhm.
prevent the detachment from happening.
Great.
Uh, it's not straightforward in some cases,
Sure.
but this is what can be done. Just cover one eye every once in a while and
Mhm.
take a look, and then cover the other eye and do the same. And whenever you feel uncomfortable with your vision, any black spots, anything, just seek the ophthalmology
Right.
advice, and we will check the retina. And if there's nothing, we'll tell you there's nothing, and we will give you the same instructions, which is if you see flashes again and floaters are become more, come, so that if there's a break, we will laser it.
Great. I think that's excellent advice. So, and again, as a general rule, just for the community who's listening to us, go for an annual checkup. But if there are any problems, at all with your vision, if you see floaters or anything at all, any symptoms, right away, please go to your ophthalmologist. It's very, very important. Eye is a very, very important organ for us. So we must look after it. So just going on to some other questions about retinal detachment.
Yeah.
So the question is, to a layperson, the symptoms of retinal detachment and cataract could be similar. So how is there a way for them to know, or is this is something which the ophthalmologist can only help?
So a cataract will happen in a more gradual, is more gradual. It's something that develops over months to years, usually,
Okay.
unless there's something. Retinal detachment is more sudden. Again, flashes and floaters are red flags for retinal detachment. And for cataracts, cataract usually it's the only it will cause decreased vision.
Okay.
The way that the pattern of decreased vision in a cataract is more like it's like you're looking at something through foggy glass,
Hmm.
while in retinal detachment it's it's a dark curtain coming at the
Hmm.
vision. So these are the and if and again any if somebody's coming for cataract, part of the examination is the examination of the retina. So once you go to an ophthalmologist, we will tell you exactly what you have. But
Right. Thank you so much. And again, like you're saying, of course, you very well differentiated, how the symptoms could present. But again, please, instead of, trying to diagnose, I think it's always best to go to an ophthalmologist and get your eyes checked. Another question about retinal detachment, what should be the time limit? So within 6 hours, 8 hours, 12 hours to get the best results from surgery.
okay, so we divide this into macula on and macula off.
Mhm.
So macula is the center of vision.
Right.
If the detachment reached the macula already, surgery, there's no difference between doing the surgery now or after 1 week or 10 days, maximum 10 days.
Mhm.
Uh, macula off is worse than macula on, but macula off does not mean that that's it, the vision is lost.
Right.
Macula off means that uh, the outcome is not different whether we do the surgery today or after 1 week. If macula is on, meaning the detachment is not reaching the center of the vision, surgery
Mhm.
is usually done within 24 to 48 hours,
Right.
uh, so that the macula is not involved. And in that case, we are sure about the outcome. That's it. So it's not that the outcome in macula off is really bad. It's that
Mhm.
the outcome for macula on, if we do early surgical intervention, is very good. So that's why we're more urgent with macula on detachments than macula off.
Sure.
And if
Thank
once
you.
the symptoms happen, go to the emergency. There, that's the
Yes.
idea.
Absolutely. And that I think is a key point, where people start sometimes self-diagnosing or asking their friends or, and family members. So it's best to report to emergency, so you can go see an ophthalmologist and you can have these discussions then further with the doctor him or herself. Coming on to some questions about the cataract.
Yeah.
So I think you made a very good point, and a lot of us, like when we trained as doctors, which was a long time back even for me. So the old theory was that you let the cataract become mature, and then you take the lens out. But now that is no longer the case, which was a very, I think, a good point that you made. Um, so can you elaborate? You said that in 90 or 95% of the cases, cataract surgery has a success rate of 90 to 95%, right?
That's right. Yeah.
So what happens in the rest of the 5 to 10%? If you can, since it's such a
Yeah.
common surgery which is being done, can you elaborate on that,
Yeah.
please?
So 5% of the cases will have the complications that might happen during surgery.
Okay.
Complications might be caused by the surgery itself, or the patient's eye itself might have some predisposing factors.
Okay.
So the lens is usually inside of a bag. We make an opening of the bag, we remove the lens, and we put the new lens inside this.
Okay.
In some cases, the the back of the bag might open, and
Okay.
this will mean that we might need to put the lens in a different place, which is
Mm,
more to the in front of the bag, or in some cases we might not be able to put a lens, which will leave the eye with very poor vision
sure.
because it will be an eye that needs a -20 correction. So,
Mhm.
some cases we might delay putting the lens to 6 weeks after the surgery in case the eye is not stable during the surgery. This is a fraction of the cases. It's 5% of the cases. It's
Right.
explained to every patient before surgery
Sure.
uh, because no one knows, what.
Yes, yes. But again, like a 90 to 95%, success rate
Yeah.
is of course a very good statistic to work with. So another question about cataract. So can one get bifocal lenses during cataract surgery so as to avoid
Yes.
reading glasses?
Yes. We have it in HMC.
Okay.
We have multifocal. It's not it's not only for far and near. It's for far, intermediate, and near vision.
Mhm.
Uh, so the thing with these glasses, it has usually if the patient will need these glasses, the patient has needs to have a good retina. Meaning, if the patient has diabetic retinopathy, we avoid putting these lenses. But the outcome with these lenses is very good. But the issue with these lenses is halos around lights.
Okay.
It's the most common issue with the patients. Uh, Usually, in 90% of these patients, it will resolve within 6 months after the surgery, but it might persist in some of the other patients.
So
So
halos around the light. When you look at light, or how does it sort of? I'm just trying to.
any source of light, and
You're
more
right.
commonly in the dark. If you're
In
driving
the
at night, it might become very annoying.
driving at night. Okay.
That's the only issue with it.
So
So
this is with a multifocal lens, you said.
this is the multifocal lens.
Okay.
Uh, but in general, the outpatients are happy with it. And again, you might it might be good for reading, but again, if you're doing very fine stuff, you might still
Mhm.
need another magnifying lens.
Right.
It's still not perfect, uh, from manufacturing, it
Sure.
still needs some tweaks.
Great. Thank you. So just a couple more questions or a few more questions. So for angle closure, what is done first? Is it the intraocular pressure reduction by medication, or just take directly the patient to the operating theater?
And we cannot take the patient to the operating theater immediately
Right.
because the pressure has to lower, because when the pressure is high, the cornea of the eye will collect fluids, and we will not be able to see the iris well to do the laser. So
Mhm.
we need the pressure to be low. We need the inflammation in the eye to subside.
Mhm.
Once we have a clear view of the iris, and usually these patients will come with a dilated pupil. So we
Okay.
need the pupil to constrict. Once the pupil is small and we have a good area of the iris, we can do the laser then. So we need
Oh,
to be able to see well.
okay. Great. Thank you so much. So Dr. Samara, just a couple more questions. Uh, uh, these, of course, you referred to all these different diseases. These are generally, seen in adults, or what kind of, common eye diseases do you see in children?
Okay, for children, uh, I can say 80 to 90% of the cases are either squint cases,
Okay.
uh, kids who have eye misalignment,
Hmm.
uh, small kids who come with tearing. It's very
Okay.
common in kids in the first year of life to have nasolacrimal duct obstruction. This is
Okay.
also very common. And refractive errors, myopia and hyperopia. This accounts for 80 to 90% of the cases we see in the pediatric ophthalmology.
Hmm.
There's also some more serious cases like congenital glaucoma and congenital diseases, but it's not that commonly seen. Usually, patients will come with squint. We have to address what the cause of the squint is. If the patient's squint is corrected only with glasses, they have to wear the glasses and follow up with us regularly.
Hmm.
If there's still an angle of squint with the glasses,
Right.
might need a surgery to correct the squint. And for the nasolacrimal duct obstruction part,
Hmm.
uh, if the patient is under 1 year of age, we advise the one of the parents to do massage to the eye.
Right.
In 90% of the cases, it will open up by itself
Hmm.
by the age of 1 year. If the patient reaches 1 year and there's still obstruction, we might do a small procedure. which is called probing and irrigation, to kind of open the nasolacrimal duct by itself.
Sure, thank you. So just I'll just pose this last question to you, because again, I also see this as a very common. It's not a disease, obviously, but I'm talking about dry eyes. So of course, dry eyes can be related to a lot of diseases, but due to contact lens use, due to getting laser surgery on the eyes, it's a very very common. Us staying in air conditioning, travel, and things like that. So what are your thoughts about that? What kind of drops, can we use? In some cases, sometimes, I don't know, some people might recommend surgery, like, is that evidence-based? Can you talk a little bit about that,
Yeah.
please?
So for dry eyes, it depends on the degree of dryness in the eye. So for
Yes.
mild to moderate cases, they can be managed by lubricating eye drops.
Hmm.
It can be more than enough.
Right.
Uh, the only evidence base other than lubricating eye drops is omega-3 supplementation.
Okay.
Uh, if the dryness is more, we might go for a more powerful eye drop, which is
Okay.
Restasis, which is basically tacrolimus eye drops
Okay.
to suppress the immune reaction in the eye that's causing the dryness.
Hmm.
The intervention that we can do, we can put something called punctal plugs. We
Okay.
will obstruct the punctum of the eye so that the tears stay longer in the eye.
Right.
Also, there's a subset of dryness that is caused by the by meibomian gland dysfunction, meaning the fatty layer of the tear film is
Mhm.
not being synthesized properly, meaning the tear film will evaporate quickly.
Okay.
So in these patients will benefit from warm compresses, and there is we don't have it available in HMC. There is an eye drop. There are some eye drops that are specific for this subset of. Uh,
Okay, sure.
but
So again, I mean,
we
those
don't
for those
prefer
they could
surgery.
have, right. And but most of the dry eyes, like you said, if there's mild to moderate, people should be using eye drops which are easily available.
Yeah, severe dry eye is still something that we're trying to understand. It's not fully understood.
Sure, sure.
It can actually even cause corneal scarring and corneal blindness in some people.
Sure. So, Dr. Samara, I think we are, we've gone beyond 5 p.m. Here in Qatar, but the time went by so quickly. And again, my gratitude to you from Dr. Mamtani, who's our Vice Dean here at Institute for Population Health, from myself and the whole team, and Weill Cornell Medicine. Thank you so much for doing this session. And I think it's been a very informative session for our community. So everybody listening to us, please look after your eyes. If you feel anything, off, if you're feeling any sign, symptom, please go to a physician, go to an ophthalmologist. It's very, very important for us to be looking after our eyes. So again, Dr. Samara, thank you so much, and inshallah, look forward to meeting you.